Some indications for prone positioning for patients with ARDS include there must be some strong evidence that proves that prone positioning would be beneficial for the patient on effects of gas exchange, respiratory mechanics, lung protection, and hemodynamics. And since prone positioning has not shown significant improvement in mortality in mild or moderate ARDS, it's best indicated for patients with severe ARDS. And that includes a PF ratio of less than 150 millimeters per mercury, inadequate oxygenation while on 50% FiO2 or greater despite the use of high levels of PEEP, more than 10 centimeters of water, and the presence of bilateral infiltrates on the chest X-ray. Some contraindications of prone positioning include an unstable spinal injury. So if there's any fractures in the spine that are unstable, that's a contraindication of prone positioning. Unmonitored or significantly increased intracranial pressures, a disturbance in the hemodynamics or the cardiac rhythm would both be contraindications as well. Preterm considerations, we need to check the operation of the vacuum for suctioning and check the integrity of the ambu bag. We need to have the crash cart with intubation supplies next to the bed, and we will check the patient's tube placement and cuff pressure. We need to have at least one person securing the tube during the turn. We need to remove devices such as any oropharyngeal airways and any aspirators from the oral cavity. We need to pre-oxygenate the patient using 100% FiO2 for at least 10 minutes and suspend the patient's diet for at least 2 hours before the turn and assess the need for increases in sedation or muscle relaxant. And we need a physician's order. That is the most important thing. Technique for placing the patient in prone position manually is the bed needs to be flat and the patient's arms need to be down by their sides, and we need to place any and all tubes and lines that are connected to the patient along the patient's side. To move the patient, we would use the envelope maneuver. We'll use the one moving sheet on top of the cushions that are placed for the patient with the same arrangement as the lower sheet. We're going to join the upper and lower sheets by their sides and corners and wind the ends until they become tight, like a handle, and close to the patient's body in order to proceed with the envelope maneuver. We'll move the patient using the envelope made with both moving sheets up to the side of the bed opposite to which of the side that the turn will occur and the mechanical ventilator. If the patient has chest tubes, we need to move the patient to the side where the drain is going to be so that the tube and the drain will be on the same side of the bed. That'll prevent the tube getting caught underneath the patient's abdomen whenever you turn them. We'll lateralize the patient carefully at the command of the leading professionals. There will be one person leading the turn. They're going to be having their eyes on everything and telling everybody what to do. And the turn the patient into prone position with the cushions positioned below the chest and the pelvis. And I have a video of the prone positioning at the end of this presentation. To assess the effectiveness of prone position, we're going to obtain an ABG, and the PaO2 should increase at least 10 millimeters of mercury. That would show improvement. We're going to hear some crackles in the lungs in the areas that we were diminished before during chest auscultation. Improvement in the chest X-ray or the CT. So you'll see improvement in the infiltrates. You'll see more black on the chest X-ray. And we're going to calculate the PF ratio to increase the PF ratio by 20 millimeters of mercury, and that would show improvement. The patient should also be in prone position for 18 hours and then turn to supine for 6 hours. Here's a picture of a chest x-ray. The top x-ray is the pre-prone position. You can tell how it's really whited out. It has that ground glass appearance with the infiltrates. And you don't see much black there, so that means there's not much air in there. And then the post-prone, you see more black, an improvement in the infiltration, and you can tell that their lungs are being able to expand just a little bit more to allow more volume. Here's pictures of the CT scan. A and C, which are the top and bottom one on the left side, are the pre-prone images, and they show the increased consolidation. You can see all the white consolidation in the lungs. And then B and D, the top and bottom images on the right side, you see more black, you see less consolidation, so it shows improvement. Some skin protective measures to prevent skin breakdown in prone position. We're going to remove any leads that are on the chest and place them on the back or the sides if possible. We're going to apply padding such as foam pads, blanket rolls, and pillows around the patient's forehead, cheeks, shoulders, knees, anterior ribs, and ankles. We can also use a face cradle. We can add foam dressing around any chest tubes or ports to form a barrier between the skin and the tubing. And we need to check the skin integrity often. Here is a picture of the face cradle. It's just an adapter that you can put to the end of some beds that allow for the nose and the mouth to be shown through there so that their ET tubes can go through there. Okay, so first you will gather the ends and wind them up tight and form handles. And you'll pull your patient towards you to the edge of the bed, leaving the longer side of the sheet on the side that the patient would be laying on. And then you will just lift up and gently turn your patient into prone position.